taken to Washington for the World Congress into the appropriate frame of mind. So as you all know, those of you who have been watching our earlier presentations, we've been concentrating on how best to describe the channels we find between the ventricles. So today we complete that. I noticed that we have available, Norman is with us, Adrian was with us, Diane is with us. For today, Diane has again prepared a wonderful set of video presentations that will go along with my didactic presentation. So we hope you have lots more questions. In fact, that's not strictly true, because I hope that today's presentation will have answered the questions that you posed during our previous sessions. And if all goes well, at the end of today's sessions, everything will be clear. But should it not be clear, then please do continue to ask us questions. So Sasha, let us hope that the presentation plays with a little more success than did the cello guys. And let's get on with the final session of the summer series of morphologic presentations for the Congenital Heart Academy. Well, good afternoon to you all, ladies and gentlemen. This afternoon, we complete our series of presentations in which we have been discussing deficient ventricular septation. Now you'll see my first point: does the knowledge of morphogenesis help us to understand deficient ventricular septation? I hope that those of you who have been with us over this summer session will appreciate that that is absolutely the case. And I thought our previous session was particularly important in this respect. So now we are going to continue to go from morphogenesis to the definitive anatomy. And what we're going to try to do today is to show you that it is indeed the case that we can use the same approach to all those hearts in which we find evidence of deficient ventricular septation. So how should we proceed? Well, we should start by reviewing yet again the morphogenesis and the embryology of deficient ventricular septation, because that is our starting point. So you will remember, I hope, that we showed you last session that during the process of ventricular development, the key feature was the remodeling of the interventricular communication. We started off with a primary interventricular foramen. And then, so as to get the inlet of the morphologically right ventricle, there was expansion of the atrioventricular canal. And that gave us the secondary interventricular foramen. The key stage then was the building by the embryo of a shelf within the roof of the right ventricle, or the base of the right ventricle, so that the aortic root was committed to the left ventricle. And that produced an aorto-right ventricular communication, which we agreed could also be called the tertiary foramen. And that was the foramen that was closed by formation of the membranous septum. So let me review those processes for you yet again. So here we're looking at a short axis cut across the base of the ventricular mass. It's one of the episcopic data sets prepared by my good friend and colleague, Tim Mohan. As you can see, it is from a human heart. It is at the beginning of the 5th week of development, or rather, nearly at the end of the 5th week of development. And this is Carnegie stage 14. So you're looking up at the base of the ventricular mass, and there you can see the surrounds of the atrioventricular canal. And the key to our understanding at this stage is that the orifice of the atrioventricular canal is looking exclusively into the developing left ventricle. But From the outlet part of the ventricular loop, we've had formation of the developing right ventricle, and arising from the cavity, the developing right ventricle, we have the entirety of the circumference of the outflow tract. So this is our starting point for understanding deficient ventricular septation, because at this stage, the communication between the developing left ventricle, the developing right ventricle, is the primary interventricular communication. And all the blood that is entering the heart at this stage has to pass through this communication so as to reach the outflow tract. So if I summarize what's going on at this stage, show you another picture, a cut, a suboblique cut to show you the arrangement of the developing right ventricle at this stage. That is the cavity of the developing right atrium. You see there is no communication at this stage between the cavity of the right atrium and the cavity of the developing right ventricle. But they're ballooning from the outlet part of the ventricular loop. We can see the beginning of the apical component of what will become right ventricle. And the key at this stage, it supports the entirety of the outflow tract, and that is why all the blood at this stage has to come through this primary interventricular communication. And that is because prior to expansion of the atrioventricular canal, essentially we are dealing with double inlet left ventricle and double outlet developing right ventricle. So to appreciate the anatomy of deficient ventricular septation, we can start at this point because we can see hearts that represent lack of expansion of the atrioventricular canal. But there has been one key stage, because when we see these hearts in postnatal life, almost always one of the other outflow tracts has been committed to the developing left ventricle. So what we see are the variants. Those hearts we can group together because they have dominant left ventricle with incomplete right ventricle. And this perhaps is the exemplar of the dominant left ventricle. And this, of course, is double inlet left ventricle. I'm showing you a long axis section through a heart that has double inlet left ventricle. The apical part of the dominant ventricle has fine crisscrossing trabeculations telling us that it is a left ventricle. Entering it, we have both the atrioventricular valves. Now, in the past, the nature of the second chamber has been contentious, but we now know that it is the incomplete right ventricle, because, as you will see very shortly, shown to you by Diane, it has an apical component of right ventricular type. And the communication between these two chambers is bounded apically by the apical ventricular septum and bounded cranially by the muscular outlet septum. And that is because one of the outflow tracts has been committed to the developing left ventricle. In this instance, as is usually the case with double inlet left ventricle, it is the pulmonary trunk that has been committed to the dominant left ventricle. So in this instance, all the blood going through this primary interventricular communication goes up into the aorta. And the primary interventricular communication is part of the circulation. Now, we're also very shortly going to be looking at this heart. And this is a picture of the heart that Diane will be showing you, because this is even more reminiscent of that stage I showed you during cardiac development. Because there, very nicely, you see that apical component of the developing right ventricle. But now it is the aortic root that has been committed to the dominant left ventricle. So here we have a long subpulmonary infundibulum, and this, of course, is in the setting of tricuspid atresia due to absence of the right atrioventricular connection. There has been failure of expansion of the atrioventricular canal, so there is the primary interventricular communication, and it is a muscular defect because the entirety of its surrounds are made up of myocardium. And so it is the rule that when the left ventricle is dominant, because there has been lack of expansion of the atrioventricular canal, that is why the right ventricle is incomplete. Almost without exception, the ventricular septal defect has exclusively myocardial borders. And that is the essence of the muscular defect. The only exception is when the defect extends to become juxta-arterial and doubly committed. And that can happen when the proximal outflow cushions fail to muscularize, so there is fibrous continuity between the leaflets of the aortic and pulmonary valves. But we're not going to be looking at that. We're going to be looking at the commonest example in which the defect is muscular and which it is an obligate part of the circulation. So now Diane is going to show you examples of this lesion. She's going to start by showing you an example of double inlet left ventricle with discordant ventricular arterial connections. And then she's going to show you the heart, of which I've already shown you a picture, tricuspid atresia due to absence of the right atrioventricular connection with concordant ventriculo-arterial connection.
Here we're looking at the anterior half of a heart that has a double inlet left ventricle and a rudimentary and incomplete right ventricle. Also, there are discordant ventriculo-arterial connections, which is typically the case with double inlet left ventricle. Here you can see the coronary arteries following the interventricular septum and delimiting this incomplete right ventricle. This right ventricle lacks its inlet, but has an apical trabecular component and an outlet component. The aortic valve is supported by a complete muscular infundibulum within the outlet component. The ventricular septal defect is large in this case and entirely surrounded by muscular borders. The ventricular septal defect is required to maintain systemic circulation. You'll also note that the outflow component of this rudimentary ventricle is quite short in cases with double inlet left ventricle because it is the pulmonary valve that gets moved into the left ventricle, and the aortic valve is maintained within the outlet of the right ventricle. In comparison to the last specimen, here we're looking at a heart that has the classical type of tricuspid valve atresia with concordant ventriculo-arterial connections. Concordant connections are typically associated with tricuspid valve atresia, just as discordant connections are associated with double inlet left ventricle. This specimen also has an incomplete and rudimentary right ventricle. Here you can see the anterior interventricular coronary artery following the septum and delineating this small chamber. There is no potential for an inlet component to this rudimentary right ventricle, but it does have an apical trabecular component and a well-formed outlet component. You'll note that the outlet component has a much more normal appearance than did the specimen with the double inlet left ventricle, and this is because the aorta moved normally into the left ventricle during development, and the proximal outflow cushions also formed normally, lifting the pulmonary valve up off of the right ventricular mass and supporting it by a complete muscular infundibulum. The ventricular septal defect in this case is in the inlet of this rudimentary right ventricle, and it has entirely muscular borders. This ventricular septal defect is how this right ventricle receives its blood flow.
So, when we have dominant left ventricle, incomplete right ventricle, the channel between the ventricles is essentially the primary interventricular communication. But we're going to move on now and going to show you what happens when we have the secondary interventricular communication. Because we know that the next stage of normal development is indeed expansion of the atrioventricular canal. And it is the expansion of the atrioventricular canal that gives the right ventricle its own inlet. And that means that part of the channel we saw a moment ago, we call the primary foramen, has expanded so as to surround the right atrioventricular orifice as the right atrium gains its own communication to the developing right ventricle. But here is the key. The remainder of that foramen is now the outlet for the developing left ventricle. And that is what we are going to call the secondary interventricular foramen. And we're going to see that in the setting of the congenitally malformed heart. But here is the evidence that underscores our understanding of how we get from the primary to the secondary interventricular communication. You see that I've moved on to show you a 4-chamber section at Carnegie stage 16. Again, it's a section from the human embryo. You've seen this before. It's work I did together with my colleagues in Amsterdam. Wout Lammers, Antoon Moorman. Wout at the time was still working in Amsterdam at the beginning of the 1990s. And it shows you what has happened to the ring of cells that has been identified by their reaction to the nodose ganglion of the chick. And there on the crest, the muscular ventricular septum, you see the apical part of that ring. But now we see that the cranial part of the ring is part of the parietal right atrioventricular junction. And that is because there has been rightward expansion of that primary interventricular foramen. And that means that the dorsal part of the foramen now encircles the orifice of the tricuspid valve, leaving behind the remainder of the foramen, which we can now call secondary interventricular foramen. At this stage, the entirety of the outflow tract remains supported by the developing right ventricle. So the secondary interventricular foramen is the outlet for the developing left ventricle. So to summarize, right ventricle has now achieved its inlet, expansion of the atrioventricular canal. Part of that foramen surrounds the right atrioventricular orifice. The remainder of the foramen is the outlet for the developing left ventricle, the secondary interventricular foramen. And here now I show you the next stage of development now in a mouse heart. Because this is what happens to that secondary interventricular foramen as the embryo itself enters the next stage of development by building a partition at the base of the developing right ventricle beneath the aortic root. So it's a mouse embryo during embryonic day 12.5, and I'm showing you the stage at which the embryo has built this shelf by fusing together the proximal outflow cushions. There is the aortic root, and what I want you to do is to look at its relationship relative to the developing apical muscular septum. As I hope you will agree that the aortic root is supported entirely still above the cavity of the developing right ventricle, as is the pulmonary root. So the embryo at this stage has the equivalent of double outlet right ventricle. There, between the shelf that the embryo is building at the base of the right ventricle, the aortic root, we have part of the cavity of the right ventricle. So what the embryo is doing by building this shelf, by fusing together the proximal outflow cushions, is creating a tunnel that places the aortic root in communication with the cavity of the left ventricle through the secondary interventricular foramen. The secondary interventricular foramen is the outlet for the developing left ventricle. To summarize, so as to commit the aortic root to the left ventricle, The embryo has built that shelf by fusing together the proximal outflow cushions, which then muscularize. And that has created this tunnel, which at its leftward end has the secondary foramen. Now, why is this pertinent to deficient ventricular septation? It is pertinent because the surgeon does exactly the same thing as the embryo when correcting double outlet right ventricle. He or she builds a shelf at the base of the right ventricle so as to put one or other arterial routes into communication with the cavity of the left ventricle. And then the channel, the leftward end of that tunnel built by the surgeon, is equivalent to the secondary interventricular foramen. And I can illustrate that to you in this exquisite computed tomogram prepared by my good friend Tony Levarchek, who works at the Medical University of South Carolina. So there you're looking for the left atrium connecting with the left ventricle. The right ventricle is supporting the aortic root and also the pulmonary trunk.
Okay.
But what you can see is that there is now a triangle of space subtended beneath the aortic root. And we can concentrate on two borders of this triangle. And the key border is the triangle between the aortic root and the left ventricle, because that is the left ventricular entrance to this area of space. It is equivalent to secondary interventricular foramen. It is the outflow tract for the left ventricle. But when the surgeon corrects this lesion, as with the embryo, a shelf is placed within the cavity of the right ventricle so as to commit the aortic root into the left ventricle through that left ventricular entrance to this area subtended beneath the aortic root, which is the equivalent of the secondary interventricular foramen. So the surgeon closes the right ventricular entrance to the aortic root, as did the embryo when building that shelf in between the aortic root and the secondary interventricular foramen. I hope it's obvious to you that that secondary interventricular foramen cannot be closed because it is the left ventricular entrance to the aortic root. So when you are presenting a patient who has double outlet right ventricle to the surgeon, you need to explain to the surgeon the borders of that right ventricular entrance to the arterial root. In most instances, the aortic root. In some instances, it may be the pulmonary root, but it is the right ventricular entrance that the surgeon needs to know about. So now we're going to look at the anatomy of that right ventricular entrance to the aortic root, shown to you by Diane in a heart that has double outlet right ventricle with subaortic defect.
Here we're looking at a heart that has the anterior wall of the right ventricle and the arterial trunks removed, and it does have a double outlet from the right ventricle with a subaortic defect. You can see that there is no pulmonary stenosis. This is the outlet septum, which is now a prominent right ventricular structure, and this is the ventriculoinfundibular fold. My probe lies within the secondary interventricular foramen, which is now forming the left ventricular outflow tract. If I replace the free wall of the right ventricle, matching up those muscle bundles, namely the outlet septum and the ventriculoinfundibular fold, you can see where the surgeon is now going to have to place his patch to tunnel the aortic valve back into the left ventricle. So the patch will run along the ventriculoinfundibular fold in anterior superior position, along the outlet septum, all of those areas safe and avoiding the conduction tissue. The inferior border lies within the limbs of the septomarginal trabeculation, and the danger zone, which is along the posterior inferior border, is where there's fibrous continuity between the tricuspid valve and the mitral valve, rendering this defect perimembranous. So you can see how that patch would actually tunnel the aorta back into the left ventricle. So it's important for the surgeon to know what the borders are of the defect so that they can accurately and correctly place their sutures to not damage the conduction tissue. If we look at a specimen cut in a 4-chamber plane with a double outlet right ventricle, here you can see the aortic valve is more committed to the right ventricle. This is the tricuspid valve, this is the mitral valve, and here you can see they're in fibrous continuity. This is the crest of the muscular ventricular septum. So it's important for the surgeon to know that this is the area they'll place their patch to tunnel the aorta back into the left ventricle, and that this area is the secondary interventricular foramen and now forms the left ventricular outflow tract.
So now you've seen the secondary interventricular foramen. I've also shown you that if development proceeds normally, then the aortic root is transferred to the left ventricle by the building of the embryo, by the embryo of that shelf at the base of the right ventricle. But before the aortic root is completely committed to the left ventricle, there is a space at the dorsal margin of that shelf. And this is the aorto-right ventricular communication. And in normal development, that aorto-right ventricular communication, which we can also think of as the tertiary interventricular communication, is closed by the membranous septum. Before I get to that complete stage, however, I'd like to show you an intermediate stage, because you are all aware that in some instances we have overriding of the aortic root with malalignment of the muscular outlet septum. And the exemplar of that is, of course, tetralogy of Fallot. But we can also see the step at which we have overriding of the aortic root in the setting of development. So here is that self-same heart I showed you from the developing mouse, in which the cushions were building a shelf in the base of the right ventricle. But this is a cut very much at the back of the right ventricle, showing you the aortic root overriding the crest of the muscular ventricular septum. And again, we have the secondary interventricular communication, which is the exit for the morphologically left ventricle. But now you can see that tertiary interventricular communication that's going to be closed by the membranous septum. The secondary communication is the outlet, left ventricle. The tertiary foramen is the persisting communication between the right ventricle and the aortic root, and that is the space that has to be closed to complete ventricular septation. And so, tetralogy of Fallot is the intermediate stage here, and I can illustrate that again using one of Tony Levarchek's wonderful computed tomograms. So now you're looking at the aorta, left ventricle, the right ventricle, and again I'm going to create a triangle of space beneath the circumference of the aortic root. And now I hope you can see even better that it has two specific borders. It has the left ventricular entrance to the conus, to the triangle of space, and that is the secondary interventricular communication. But it also has the right ventricular entrance, and this is equivalent to the tertiary interventricular communication, and this, of course, is the space that will be closed by the surgeon. So when the surgeon is closing or correcting tetralogy of Fallot, he or she places a patch within the right ventricle so as to close off the aorto-right ventricular communication. And I hope you will all agree that that is the space we call the ventricular septal defect. I hope you can now see that it's the equivalent of that space that is closed by the surgeon when tunneling the aortic root, or perhaps sometimes pulmonary route, to the left ventricle in the setting of double outlet right ventricle. And it is again in tetralogy of Fallot, it is the borders of this space that require description. So now we're going to look at that space, and Diane is going to show you this space in two particular settings. In one where we have a perimembranous defect, but then in another heart with tetralogy of Fallot, in which we have a muscular malalignment outlet defect. But remember, it is the right ventricular entrance to the space that is subtended beneath the overriding aortic root.
Here we have a heart that has tetralogy of Fallot, and you can already appreciate the extensive right ventricular hypertrophy. The aorta is anterior and rightward of its usual position and virtually side by side with this hypoplastic or small pulmonary trunk. The right ventricular outflow tract is stenotic, secondary to anterior deviation of the outlet septum, and also secondary to hypertrophy of the septoparietal trabeculations, which are helping to put an extra squeeze on this already narrow subpulmonary outflow tract. If we look at the defect from the right ventricle, you can see the aortic valve looking into the right ventricle or overriding the septum and being supported along its anterior superior border by the ventriculo-infundibular fold. The defect is extending into the outlet of the right ventricle or between the limbs of the septomarginal trabeculation. The medial papillary muscle arises from that caudal arm. This defect extends to become perimembranous, where we have fibrous continuity between the tricuspid valve and the mitral valve along the posterior inferior border. So the surgeon will patch this from the right ventricle, placing sutures along this ventriculo-infundibular fold, along the outlet septum and the superior or caudal or cephalic arm, I should say, of the septomarginal trabeculation, with the sutures being safely away from the conduction tissue along these aspects. In this area where there is perimembranous extension or fibrous continuity between the atrioventricular valves is the danger zone for placing sutures and damaging the conduction tissue, because as I mentioned previously, it will run along this posterior inferior border and emerge relative to the medial papillary muscle and extend along the septomarginal trabeculation. If we look at the specimen from the left side, you can see nicely how the aorta is peeking into the right ventricle, but it is mostly committed to the left ventricular aspect, so that the surgeon must close the defect from the right side. Here you can see that ventriculo-infundibular fold, in part supporting the aortic valve over the right ventricle. In this area is where we have the fibrous continuity between the tricuspid valve and the mitral valve, and we also have a nice remnant of the membranous septum here, where sutures can safely be placed to repair this defect because it is away from the crest of the ventricular septum. The left bundle branch will emerge in this area where the tricuspid valve and mitral valve are in fibrous continuity and then ramify over the left ventricular septum. This is another smaller heart with tetralogy of Fallot, where we can also appreciate the significant right ventricular hypertrophy. The aorta is anterior and rightward of its normal position or side by side with this hypoplastic pulmonary trunk. The ventricular septal defect, again, is an outlet defect extending between the limbs of the septomarginal trabeculation. The outlet septum is deviated in anterior superior position, causing subpulmonary stenosis or right ventricular outflow tract stenosis. And you can also appreciate from this aspect that the pulmonary valve was bicuspid in this case. The defect extends between the limbs of the septomarginal trabeculation, and this specimen differs because the caudal limb reaches the inner heart curvature, so that along the posterior inferior border there is a muscular bar. The ventriculoinfundibular fold, again, you can see supports the aortic valve within the roof of the right ventricle and where it overrides the interventricular septum. The membranous septum will remain intact in this specimen so that the conduction tissue will be more protected by this muscular bar. Again, the surgeon will repair the defect from the right ventricular aspect, safely putting sutures along the ventriculoinfundibular fold, the outlet septum, and the cephalic arm of the septomarginal trabeculation, with this specimen more amenable to repair because it does not have the fibrous continuity between the tricuspid and mitral valve, so that the conduction tissues are a bit more protected by the muscular bar. The right bundle branch will emerge relative to the medial or papillary muscle and then extend along the septomarginal trabeculation. If we look at the specimen from the left side, here you can see where the aorta is supported by that ventriculoinfundibular fold and where it overrides the ventricular septum looking into the right ventricle. Here is that posterior inferior muscular bar and the membranous septum that remains intact in this specimen. So surgical repair is a bit easier in this case with that posterior inferior muscular bar. The conduction tissue, or I should say the left bundle branch, will emerge right in this area where the tricuspid and mitral valves are in fibrous continuity relative to the membranous septum, and then it will ramify over the left ventricular septal surface. So last but not least, we should look at a specimen cut in 4-chamber view that has tetralogy of Fallot. And here you can see the tips of the right and left atriums, the morphologically right ventricle and the morphologically left ventricle, with this being the crest of the ventricular septum. So you can see that this defect extends to become perimembranous with fibrous continuity between the tricuspid and mitral valves, and this is the aortic valve. Here, if I place my probe along the ventricular septum, you can see that it overrides the septum about 50% to the right ventricle and 50% to the left ventricle. So the surgeon will place their patch in this area to put the aorta back into communication with the left ventricle, and this area here would be disastrous if a patch was placed there because no blood would be able to get from the left ventricle out the aorta. And this is the area that is the secondary interventricular communication and the left ventricular outflow tract.
So now we are in a position to see what happens if development goes on and proceeds normally, such that the tubercles of the atrioventricular cushions are able to close that aorto-right ventricular communication, which we can also call the tertiary foramen. And what I'm going to show you is that it is failure to close this communication that leaves the isolated perimembranous defect. But we also need to look at the components that close the tertiary interventricular communication, or the aorto-right ventricular communication. And you'll remember, I hope, that in previous sessions I have called these entities that close this tertiary foramen, I've called them the tubercles, because that's how they were initially described by a man called Odgers, who described formation of the membranous septum in the 1930s. And I was asked in the last session whether I could show you the tubercles. So here they are in a mouse heart. It's an oblique subcostal cut. It's towards the end of embryonic day 12.5. The tertiary foramen has almost but not quite being closed. There you can see what's happening to those proximal cushions that built the shelf in the roof of the right ventricle. They are muscularizing. If development proceeds normally, those muscularizing cushions will become the freestanding subpulmonary infundibulum. But there are those tubercles. They are the rightward ends of the atrioventricular cushions that have divided the atrioventricular canal into the mitral and tricuspid orifices. And they are going to fuse together to form the membranous septum, and then the rightward ends will also become part of septal leaflet of the tricuspid valve. So there they are closing the tertiary interventricular communication. And this is what happens if all goes according to plan. It's a human heart. We are at the end of the 7th week of development. There you see the mitral valve, the ventricular septum, the pulmonary root. And separating the pulmonary root now from the aortic root, we have those muscularizing outflow cushions. But there are those two tubercles that have now fused together. They have blocked off that tertiary interventricular communication, creating the tunnel that puts the aortic root into communication with the left ventricle through the secondary interventricular foramen. So the tubercles become the membranous septum, and they have closed the tertiary interventricular communication. But if they don't close the tertiary foramen, then as in this mouse in which Dr. Mohan perturbed the furin enzyme, we have a persisting tertiary interventricular communication that we call the perimembranous central ventricular septal defect. And very shortly, Diane is going to show you an exquisite example of this as was seen in human heart. What we see here, aortic root, almost committed to the, or indeed is committed to the left ventricle. The cushions have muscularized, have fused, have almost but not quite blocked off the tertiary interventricular communication, because in this instance, the fused cushions have been unable to form membranous septum, leaving us a persisting aorto-right ventricular communication that we call the perimembranous ventricular septal defect. And this is what it looks like in a 4-chamber section. In this instance, we have a reasonably sized central perimembranous ventricular septal defect. There you see the aortic valve, the mitral valve, the phenotypic feature, fibrous continuity posterior-inferiorly between the leaflets, the mitral and tricuspid valves, and those cushions have fused the tubercles and have formed a membranous flap, but they have been unable to close the tertiary interventricular communication. So again, we can create this triangle of space beneath the aortic valve, and we can look at its entrances. And now it is the right ventricular entrance that is the tertiary interventricular communication, the aorto-right ventricular communication. And that is what we're going to call the perimembranous ventricular septal defect. Because, of course, the left ventricular entrance has remodeled to become the outflow tract for the morphologically left ventricle. So now, let's look at this situation in the definitive heart. And let's remember that as with double outlet, as with tetralogy, it is that right ventricular entrance that is closed when the surgeon corrects the perimembranous ventricular septal defect, because it is the right ventricular borders to major surgical significance, because that is the area around which the surgeon is going to place a patch. So now let's look at a small central perimembranous ventricular septal defect, and let's look also at a perimembranous ventricular septal defect with malalignment of the muscular outlet septum.
As I was preparing for today's session, I came across this interesting little heart and thought it might be pertinent to the discussion. So here we see the septal surface of the morphologically right ventricle with the tricuspid valve in the inlet and the pulmonary valve within the outlet and supported by a complete muscular infundibulum. Here is the septomarginal trabeculation with the cephalic arm rising up to become part of the subpulmonary muscular infundibulum, and you'll note that it looks a bit short in this case. Also, we have the caudal limb, which extends back to reach the inner heart curvature or the ventricular infundibular fold, and the medial papillary muscle is arising from that caudal limb. Here we see where the supraventricular crest inserted between the limbs of the septomarginal trabeculation, and in this heart it looks as though this area is a bit more anterior and cephalic relative to the aortic root than usual. Also, you'll note that there is this little notch in the caudal limb of the septomarginal trabeculation. I'm going to try and backlight the area so that we can see where our membranous septum is located relative to the other structures. So with the light, you can see that small notched area, and here is the interventricular component of the membranous septum. So that the tubercles in this case were fairly normally formed, but when we get to the left side, we'll see that the cushions could not completely close this defect. This is probably the smallest central perimembranous defect that I have seen yet. Here we can see the mitral to aortic fibrous continuity, this being the non-coronary aortic valvar sinus, and this the right coronary aortic valvar sinus with the right coronary artery just there, just below the sinutubular junction. Here is a relatively normally formed membranous septum in its usual position beneath the interleaflet triangle between the non and the right coronary aortic valvar sinuses and leaflets. And you'll see that right above, or I should say below this right coronary leaflet, there is a tiny little hole. So you can see that the tubercles were almost sufficient along with the atrioventricular cushions in closing this area. But remaining here is this tiny little central perimembranous ventricular septal defect. And if I turn this specimen over, right where that defect is right where the small little notch is in that caudal limb of the septomarginal trabeculation. This specimen has a perimembranous ventricular septal defect along with a restrictive muscular ventricular septal defect that is virtually in the inlet component of the septum just behind the septal leaflet of the tricuspid valve. Here we see the oval fossa and a dilated orifice to the coronary sinus, which is secondary to a persistent left superior caval vein. If we look at the borders of the triangle of Kalk, one of the borders is marked by the hinge point of the tricuspid valve and another by the tendon of Totaro. The eustachian valve is not particularly prominent in this case, but if I tug on that area, you can see that tendon coming into prominence here and pointing towards the apex of the triangle, which is where our atrioventricular conduction axis is going to be located. Relative to the borders of this ventricular septal defect, the conduction axis will run along the posterior inferior border, and because this specimen is showing us a perimembranous ventricular septal defect, where we have fibrous continuity between the tricuspid valve and the mitral valve along the posterior inferior border, the conduction axis can be in peril in this area when there is a surgical repair taking place. The right bundle branch will emerge relative to the medial papillary muscle, which arises from the caudal limb of the septomarginal trabeculation, and then it will extend along the septomarginal trabeculation to the moderator band and the right ventricular apex. You'll also note that this specimen has anterior deviation of the outlet septum with no pulmonary stenosis, and this shows us nicely that the defect is the entrance to the aortic root. Here you can see a little bit of the aortic valve overriding the ventricular septum, so that the posterior inferior border becoming perimembranous is very important for the surgeon to know when they are performing a surgical repair. This muscular ventricular septal defect will be well away from where the conduction axis will run on the right ventricular side. And when we look at both defects from the left ventricular side, again, you can see where the left bundle branch will emerge, and it is well away from this muscular defect. The conduction tissue will be anterior and superior to it, and along the posterior inferior border of the muscular ventricular septum relative to the perimembranous extension of the ventricular septal defect.
So now, in that second heart that Diane showed you, there was malalignment between the muscular outlet septum and the apical septum. I need to emphasize now one more feature, however, because malalignment is important. As you've seen, usually it is between the apical muscular septum and the outlet septum. That was the setting in tetralogy. That was the setting in the Eisenmenger defect. But we can have malalignment in one more key setting, and that is when there is straddling and overriding of the tricuspid valve. Because now we must return to that transition from the primary to the secondary interventricular communication. Because we have a particular type of ventricular septal defect, which is perimembranous, and which represents incomplete expansion of the atrioventricular canal. And here you see a 4-chamber cut through such a heart. There you see the essential feature, malalignment between the atrial septum, top of the screen, the apical ventricular septum, bottom of the screen. Because of the malalignment, there is overriding of the orifice of the tricuspid valve, and there is also straddling of the tension apparatus. So once again, we can make a triangle of space that is subtended beneath the orifice of the overriding valve. But this time, it's the tricuspid valve that is overriding. So when you look at the entrances this time, we cannot close the right ventricular entrance, because the right ventricular entrance is permitting the blood to pass from the right atrium into the right ventricle. So in this situation, the surgeon would have to close the left ventricular entrance if he or she was hoping to complete ventricular septation. And now we need to take into account the key feature of this specific malformation, malalignment between the atrial septum and ventricular septum, and that is the location of the atrioventricular conduction axis. Because in this setting, by virtue of the malalignment, the atrioventricular node is no longer at the apex of the triangular cock. The conduction axis is postero-inferiorly located, but the node is formed at the point where the muscular septum comes up inferiorly and joins the atrioventricular junction. So now Diane is going to show you the essence of straddling and overriding of the tricuspid valve, where there is a perimembranous malalignment inlet defect. The defect reflects atrioventricular septal malalignment. As you will see, it's perimembranous because there is aortic to mitral fibrous continuity, there is tricuspid to mitral fibrous continuity. What we're going to emphasize is the anomalous location of the atrioventricular node. And also, in this instance, the surgeon would need to close the left ventricular entrance so as to achieve septal integrity. So here, let's look at those hearts.
This is a very nice specimen from the Idris Archive at the Lurie Children's Hospital in Chicago, and it is showing us straddling and overriding of the tricuspid valve. The muscular interventricular septum in these cases no longer reaches or extends to the crooks of the heart, and this is secondary to malalignment between the atrial and ventricular septums. And this is a consequence of incomplete expansion of the atrioventricular canal during development. The atrioventricular conduction axis can no longer be located in its normal position at the apex of the triangle of Koch, and that's secondary to this atrial and ventricular septal malalignment. So it gets repositioned in an abnormal location where the crest of the muscular ventricular septum meets the atrial musculature, and in these cases there is a long non-branching bundle with variable branching of the left bundle branch across the crest of the muscular ventricular septum, but we can predict where the right bundle branch will emerge by marking the medial papillary muscle, and it will emerge in this position and extend onto the septomarginal trabeculation. If we look at this on the short axis, you can see how the atrial and ventricular septums are malaligned, and when we look at the left ventricular aspect, there is a small papillary muscle across the interventricular septum and supporting the tricuspid valve within the left ventricle. This is another specimen with straddling and overriding of the tricuspid valve, but cut in a 4-chamber plane. Here you can see the pectinated right atrium and the smooth-walled vestibule of the left atrium. Between them, we have the flap valve at the floor of the oval fossa, or the primary atrial septum, and the second true component of the atrial septum, which is this muscular buttress. During development, this muscular buttress forms portions of both of the atrial vestibules and allows for separation of the atrioventricular valves. You'll note that there is a portion of muscle here at the atrioventricular junction, but I will tell you that this defect did extend to become perimembranous. Here you can see the morphologically right ventricle with a dysplastic tricuspid valve. Here is the crest of the muscular septum and the left ventricle with the mitral valve in its inlet. If I place my probe along the plane of the atrial septum, you can clearly see that it is malaligned from the plane of the crest of the muscular ventricular septum, so that there is atrioventricular septal malalignment. The tricuspid valve, as I said, is somewhat dysplastic and is in part supported within the left ventricle by this papillary muscle and these tendinous cords. When you have straddling and overriding of the tricuspid valve, the defect is in the inlet portion of the right ventricle, and the conduction tissue can no longer be located at the apex of the triangle of Koch. So it gets placed or develops in an anomalous position where the muscular ventricular septum meets the musculature of the atrium. You'll have a long, non-branching bundle that extends along the left side of the ventricular septum, and then the right and left bundle branches will vary in how they extend into the right and left ventricular walls. The surgeon will repair the left entrance of this defect, taking into consideration any papillary muscles or tendinous cords that might be involved in that repair.
So what I've shown you thus far today is that apart from the hearts with dominant left ventricle, the other defects we've been looking at have been at the margins of the muscular ventricular septum. They've been adjacent to the leaflets of the arterial valves, or in the setting of straddling tricuspid valve, directly adjacent to the leaflets of the atrioventricular valves. They have not been muscular. But despite that, apart from straddling tricuspid valve, it is the right ventricular borders that have been closed by the surgeon to restore septal integrity. And this, in fact, is also the case for those defects we find within the apical muscular septum. So we started with muscular defects, but those muscular defects reflected the primary interventricular communication. We couldn't close those defects because they were obligate parts of the circulation. But the defects we're going to look at now are within the apical septum, and they do need to be closed. In fact, they are very common, isolated ventricular septal defects. And this is such a defect. There you see it, surrounded by the myocardium of the apical ventricular septum. But this one opens to the inlet of the right ventricle. It is a muscular inlet defect. And this is what it looks like if you make a 4-chamber section through such a muscular defect opening to the inlet of the right ventricle. There it is. You can see it has exclusively muscular borders. But again, if the surgeon was going to close this defect, or at least if the surgeon was going to stop shunting through the defect, a patch would be placed on the right ventricular entrance. But obviously, that would not, in fact, close the defect, because the remainder of the defect would still be a channel which had been closed at its right ventricular end. So it's not strictly the case that the surgeon closes these defects. The surgeon places a patch such as to prevent shunting through the septum. But many of you as interventionists now have the capacity truly to close such inlet muscular ventricular septal defects. And this is what happens when a device is placed within such a muscular defect, because one arm of the device will be on the left ventricular aspect, the other arm will be on right ventricular aspect. The device itself will properly close the muscular ventricular septal defect. And Diane's now going to illustrate that anatomy to you.
Here we're looking at the right atrioventricular junction. We can see the entire septal surface of the right ventricle, and there is a mid-septal muscular ventricular septal defect. The surgeon in this case would be repairing this defect from the right ventricular side and placing the patch along these muscular borders within the right ventricle. This specimen most likely could not be repaired by the interventionalist because there is a prominent papillary muscle with some tendinous cords extending across the left ventricular aspect of the defect and may interfere with that interventional procedure. So that if we look at the left ventricular side of this mid-septal muscular ventricular septal defect, there you see that muscular bar and a few tendinous cords extending across the expanse of the defect. If we look at a 4-chamber view of a mid-muscular ventricular septal defect, here you can see the tricuspid valve in the right ventricle, the left ventricle, and some of the mitral valve, and this is the interventricular septum. There is the nice mid-muscular ventricular septal defect, and this defect would be very easy to close by the interventionalist. They would insert the device, which would expand on both the left and right sides of the defect, completely closing it, where it extends through the mid portion of the ventricular septum. I have one specimen that does have a device, but on the right ventricular side, it is not easily seen. It is way down at the apex. This is the septomarginal trabeculation and the moderator band. The anterior papillary muscle has been truncated here, secondary to how the specimen was sectioned. But if we look from the left ventricular side, there we can see the device at the extreme apex of the left ventricle and partially covered by endothelial cells.
So, ladies and gentlemen, I hope we've put the morphogenesis into the context of the anatomy of deficient ventricular septation. I hope we've been able to show you over our recent sessions how the understanding of an embryology now permits you to appreciate why we have muscular defects, why we have defects that can be juxta-arterial, because the outflow cushions have not muscularized, or why we have defects that are perimembranous, because the embryo has failed to close the tertiary interventricular communication or the aorto-right ventricular communication. But if we put everything together, then surgeons usually do not close the defect. They block off the right ventricular entrance to the defect so as to prevent shunting between it. And here is the key to what we have been trying to establish. If there is double outlet right ventricle, if there is tetralogy of Fallot, if there is an isolated ventricular septal defect apart from straddling the tricuspid valve, it is always the right ventricular entrance to the space subtended beneath the overriding or the arterial route that is closed to restore septal integrity. So arguably, it is that right ventricular entrance that should be considered to represent the defect. That point remains controversial because many of you in the setting of double outlet right ventricle will continue to describe the exit from the left ventricle, the secondary interventricular communication, as the ventricular septal defect. But what I hope we've been able to show you is that using that is not logical, because the area that is closed by the surgeon, right ventricular entrance, is the space that in tetralogy of Fallot, perimembranous defect, that is the space that you will call the ventricular septal defect. So thank you all for your attention, and I hope now we've put everything together. Thank you. Okay, ladies and gentlemen, so that was the presentation for you, and we now have our discussants. Norman, over to you.
Bob, thank you very much for, and Diane, thank you so much for making this as clear as it has been. It's an absolutely beautiful presentation, and the specimens were just so well augmented the concepts that you showed here. Bob, there remains for me just one little gadfly problem here that I've looked at and that I think that you can clarify for us. And that's that when we look at all of these examples when there is override in the patients with tetralogy or perimembranous ventricular septal defects, it appears that the aorta is in fibrous continuity with the mitral valve. And in double outlet, that was not the case. Now, I think your example, the diagram that you showed where there's this tunnel, shows very well that this, in the embryo at least, that this tunnel is does not permit or commit the aortic leaflets to the mitral valve, but as I see it, that this is a process of development that occurs perhaps after the embryonic period. And I think there must be a number of people that have been using a different philosophy from ours over here, that you could maybe resolve these issues for them so that we can understand this lack of importance of mitral aortic fibrous continuity.
And you make a very good point there, Norman, because we're talking about two different entities. You're 100% correct. that when the aortic root is first transferred into the left ventricle, it still has a muscular subaortic infundibulum. But at that stage, there is fibrous continuity between the leaflets of the mitral and tricuspid valves. So it's the mitral tricuspid continuity that is the essence of the perimembranous defect. Now, when the membranous septum closes off that aorta-right ventricular communication, the membranous septum itself becomes part of that area of continuity. Now, in the hearts that you show today, Diane showed one beautifully. And that was the example she showed you as a Traugia fellow that had a muscular outlet defect. So when that heart you looked at from the right side, there was discontinuity not only between the aortic and the mitral valve, but also between the tricuspid and the mitral valve. Yet, if you went back, and Diane showed you that membranous septum, the membranous septum, the tricuspid valve, the mitral valve were still in fibrous continuity, but you were unable to see that from the right ventricle because the caudal limb of the septomitral trabeculation had fused with the inner heart curvature. So there are two totally different mechanisms. The one mechanism is whether there is muscular continuity between the caudal limb of the septomitral trabeculation and the inner heart curvature. And that is what determines whether you have a perimembranous outlet defect or a muscular outlet defect. The second feature is the persistence of that inner heart curvature between the aortic valve, the mitral valve, and the tricuspid valve. And if that persists, you have bilateral infundibulums. But even when you have bilateral infundibulums, you can still have fibrous continuity between the mitral valve and the tricuspid valve. And so you can have bilateral infundibulums with double outlet right ventricle and still have a perimembranous defect, because we're talking about two totally different mechanisms, whether it's the inner heart curvature that persists or whether the caudal limb of the septomitral trabeculation that is formed by coalescence of of the ventricular trabeculations, whether that merges with the inner heart curvature. Does that clarify the situation for you?
It does, and I just would suggest that if we look at that diagram of yours that has the big black tunnel underneath the valve, that perhaps that if we understand development correctly, that there is a process of moving of the aortic root towards the mitral valve in development, so that in fact, the whole concept of mitral aortic fibrous continuity becomes moot in terms of making the diagnosis of double outlet.
Absolutely. You're again 100% correct, and you've perfectly understood what we've shown. And that picture I showed you of the normal heart at the stage where the tubercles become the membranous septum, at that stage, the aortic root is a long way from the mitral valve. And as you correctly infer, there is significant subsequent movement of the aortic root into the left ventricle, and that occurs concomitant with the attenuation of the inner heart curvature, which becomes fibrous rather than being muscular. And you are correct, the presence or absence of bilateral conuses or bilateral infundibulums has nothing to do with double outlet right ventricle. In fact, on occasion, you can have normal hearts in which there is a completely myocardial, completely muscular subaortic infundibulum.
Right.
Right. Well, Diane, do you want to add more comments to what you've shown us? Again, the specimens you showed us were quite magnificent. And I think your presentation of them, you get better all the time. And it was wonderful what you showed us today.
Well, just in comments to the recent discussion, I do have a case with concordant ventricular arterial connections and a central perimembranous VSD that has subarterial muscular infundibulums. So it does exist, as you said, even in the normal heart. And I think the more I do these videos, the more comfortable I get, and don't have to do as many takes. So it's getting easier and easier as we move on. So I'm glad they're all helpful.
Well, we're pleased to have Adrian with us today. Adrian, I'm sure you have some points to make. Were you happier with today's videos?
Hello, thank you very much. And I'll join the chorus for congratulating Diane, because I'm one of the people who are trying to get this kind of videos, and I can tell you how difficult they are to make. It's not only about having the right words, but you have to match your words with your hands, with your hearts, which can be very slippery, with the camera. So Diane, you're really, really brilliant in doing these videos. Thank you very much indeed.
Adrian, for you as a surgeon, it should be easier.
Well, you'd be surprised. Now, the discussion that Norman started has some surgical impact, because what we know when we have a bilateral cone or we have aorto to mitral discontinuity is that the risk of post-repair left ventricular outflow tract obstruction is higher. That infundibulum, that conus that can be present in these cases of double outlet right ventricle, they do pose a higher risk for us. They are difficult, and we do get that kind of obstruction in these cases. That's not the case, obviously, when in hearts like tetralogy, where the aortic root is also dilated. It's a larger root, but that's not the case in other double outlet right ventricles. So I sympathize with those surgeons out there who would not consider this detail as being a minor one from a surgical standpoint. And the key is we have to describe this. We have to describe all the morphological features of these hearts. The other point I wanted to ask you was...
Before you go on, can I stop you there? Because again,
Yes.
You make an important point, because today's presentation, we emphasized very much the right ventricular entrance to that triangle of space. You're now making the key point that when the roof of the left ventricular entrance is composed of the inner heart curvature, which essentially is the bilateral infundibulum, then you also need to know that important feature of the left ventricular entrance to the root. And in fact, what you are emphasizing is that we should be describing, in the setting of double outlet right ventricle, we need to describe all these features, do we not? Not only the left ventricular entrance, which at the moment many people still call the ventricular septal defect. And as you say, that is important because it can become stenotic.
Yeah. And maybe we find a heart where we can show the CT, or we can show the video of such a heart with subaortic, with aorto to mitral discontinuity and double outlet right ventricle.
I mean, hopefully, if you have such a case, it would have been, the potential danger would have been recognized. I mean, in that circumstance, would you try to resect the myocardium and the roof of the defect?
No, because it's very risky. You imagine it connects the aortic valve with the mitral valve. So you sometimes you have to accept, or you create a baffle. Some people will try to enlarge the VSD if it's possible, but again, it doesn't come without risks for the conduction, as Diane showed. So that's why we have to describe this feature and be mindful of it. On the other point, a minor one, I've seen you started by describing the primary phases of being double inlet left ventricle, double outlet right ventricle in heart development. Could we also say that at times it may be similar to tricuspid atresia and common arterial trunk, depending on when the phases of septation happens? Because it is initially that there is absent right AV connection, isn't it? Before the expansion.
Indeed, and at the stage at which I show that, you are correct, that we're showing, in essence, tricuspid atresia, as you say, with common arterial trunk. Yeah. Absolutely.
Because this will help also people understand how many of the pathologies link to development.
Correct.
Actually. Correct. And my last point, which is maybe the most important, is the defect where we have malalignment between the atrial and ventricular septum with overriding of the orifice and straddling of the subvalvular apparatus of the tricuspid. You mentioned that these are perimembranous defects.
Correct.
Would you elaborate a bit more on that?
They are perimembranous in that within the left ventricle, there is fibrous continuity. And in fact, Diane emphasized that point when she showed you the four-chamber section. She made the point that in her four-chamber section, in the section she showed you, there was a muscular rim between the atrioventricular valves. But when she traces that forward, she finds that the leaflets of the tricuspid valve, the mitral valve, do come into continuity, and that therefore fulfills the criterion for diagnosis as a perimembranous defect. But of course, when you have straddling and overriding of the tricuspid valve, that particular area is within the left ventricle. And of course, in double inlet left ventricle, there is also fibrous continuity between the leaflets of the tricuspid, the right and left AV valves, but then they have no relationship to the defect. So in double inlet left ventricle, because you're looking at the defect from the incomplete right ventricle, it becomes a muscular defect. But the straddling tricuspid valve is the one situation where the defect is perimembranous, and yet because the orifice of the tricuspid valve has not been completely committed to the right ventricle, in that setting, you as a surgeon would need, if you were hoping to achieve to complete ventricular septation, that is the one circumstance in which you would close off the left ventricular entrance to the triangle subtended beneath the overriding valve.
Because it's an interesting situation. Clinicians will immediately compare this with conduction tissue in a common atrioventricular junction, but there is no membranous septum that forms in a complete atrioventricular septal defect, where here we say that the membranous septum tend to form. So we have a perimembranous defect.
But we also cannot directly compare it to atrioventricular septal defect, because normally with atrioventricular septal defect, despite the fact that, as you say, there is no membranous septum, the leading edge of the primary atrial septum is usually aligned with the inferior edge of the muscular ventricular septum. So still you have a conduction system at the crux of the heart, but there is one variation where in fact you have atrioventricular septal defect with left ventricular dominance, and that also with the common atrioventricular valve then has the malalignment, and that has the anomalous atrioventricular node as you find in straddling tricuspid valve.
Yeah, very interesting defect, and again, wonderful images. Thank you.
So we do have some questions. We have Muna Kanan, who asked a question that has nothing to do with what we've been discussing. She perhaps says, left atrial aneurysm, what is the cause? Well, the aneurysm is simply an expansion of the cavity of the left atrium, presumably due to a weakness of the wall, and you would take away the aneurysm and repair it. Omer Alganoid asks, what about the Gabodi defect? Well, there are two types of Gabodi defects. We have discussed those previously. The direct Gabodi defect is a defect of the atrioventricular component of the membranous septum. It is as rare as hen's teeth. The indirect Gabodi defect is a perimembranous ventricular septal defect permitting left ventricular to right atrial shunting. And then Riza Turkos asks, what is the anatomical difference between a very large ventricular septal defect and single ventricle? Well, of course, nowadays we know that a single ventricle is exceedingly rare, and that most of the examples described as single ventricle, in fact, are either big left ventricles with small right ventricles or big right ventricles with small left ventricles. The solitary and indeterminate ventricle has coarse apical trabeculations throughout. the large ventricular septal defect will have a remnant of the ventricular septum with right ventricular trabeculations on one side, left ventricular trabeculations on the other side. Adrian, would you like to add any more comments on those comments, or Norman or Diane?
The only thing that I would say is I understand sometimes the difficulty of Reza, because in the solitary ventricle, there's sometimes a ridge of tissue on the back of the ventricle that may be misconstrued as part of a ventricular septal defect. I don't really have much problem defining the difference between a very large ventricular septal defect, because I think there's almost always a muscular rim that you can recognize anteriorly as well. And the great vessel issue is certainly a key to this functionally single ventricle.
Indeed.
So I have a question. When you have a true single ventricle, why do you end up with the coarse trabeculations when the left ventricle is the first ventricle to form?
Well, I guess that when you have a solitary and indeterminate ventricle, there has not been independent ballooning of from the inlet and outlet parts of the loop. There has just been abnormal ballooning from the entirety of the ventricular loop. I mean, in fact, you have one specimen, Diane, in which the trabeculations are not all that coarse. You know, you have that one that we have a solitary ventricle. They're not always that coarse. So I think, I mean, you're asking, it's a pure speculation, but I would say it's because there is indeterminate ballooning.
Okay, because we've been discussing some of these at the nomenclature group, and sorry about the noise in the background, but we've been discussing that at the nomenclature meetings to get things ready for the World Congress. And I just thought I would ask, since we talked about this, because I hadn't heard you embryologically describe that in the past.
Well, I think Adrian will be there and will support you when you're discussing this. I think that's the Adrian, would you like to comment?
Yeah, he's been there on those discussions. So
yes, yeah. So I invite everybody to come to the nomenclature meeting, which is on a Saturday. We have a full day where we are picking up on all these details and terms, and I'm sure you will be witnessing very, very interesting discussions that will be borderlining on serious fights, I would say, because there are still quite a few terms that are not easy to unpick. So please do join us. We need you to be witnesses to these discussions and to contribute.
you should be diplomatic, Adrian, and say serious discussion, not fights.
We also have one question that's come up in the chat box, and this is from Pranav Kandachar, who says, thanks, professors. What is the relation or role of the moderator band in ventricular septation? If the looping is abnormal, can the moderator band be formed in the left ventricle? Well, the moderator band, along with the papillary muscles of the tricuspid valve, along with the septomarginal trabeculation, the moderator band, of course, is one of the septoparietal trabeculations. And we now know from the evidence that we have in the developing mouse heart that the trabeculations in the right ventricle coalesce, and they form the papillary muscles, they form the septomarginal trabeculation, and they form all the septoparietal trabeculations. They also form the conduction system, and that is why the right bundle branch runs through the moderator band. The septomarginal trabeculation then reinforces the apical muscular septum. Adrian has been asking whether the apical muscular septum is a separate entity. We know that the apical muscular septum is also formed by coalescence of the trabeculations that form concomitant with ballooning. And in fact, it is the trabeculations between the ventricles. So to my mind, the ventricular septum is the same thing as the interventricular septum, but the moderator band is a right ventriculate structure. You can have false tendons in the left ventricle. They are also made up of the conduction system. They pass from the septum to the papillary muscles. The papillary muscles, again, are formed by the coalescence of trabeculations. So the trabeculations all come together to form these things. The one thing that the trabeculations do not form is the compact myocardium. So it is a no-no to talk about non-compaction. Non-compaction, in fact, is excessive trabeculation. So we are learning much more about all of these things. So,
Bob, if I may just make one little remark about the moderator band. The human is quite unique in terms of the examples I've seen of the moderator band. It's a difficult structure to see. In the horse, which William Harvey studied, and certainly in the sheep and the cow, the moderator band is a much more discrete structure that you can see. I'm sure you've seen this also in your wanderings through comparative anatomy.
I mean, the thing about the human heart is that we look, I must admit, I've not seen the moderator band to any great extent in alternative animals. In the mouse, it's very much like what we see in the human. It extends from the septomarginal trabeculation to the anterior papillary muscle of the tricuspid valve. The one thing about the human is, and certainly in malformed hearts, is that it can show remarkable variability. And so-called two-chambered right ventricle, as you are well aware, is in many instances the freestanding moderator band, one of the freestanding septoparietal trabeculations.
Exactly. Well, I do think that I've done a lot of comparative stuff in teaching at Stanford, and they used the ox hearts, and Dr. Brownwalt and Sonnenblick, that did their original experiments on cardiac muscle, used the moderator band from cats, in fact.
Right.
And so I think that it's a much more discrete structure, much easier to dissect off than it is in the human heart. And obviously, I haven't seen too many mice hearts with that condition. Otherwise, I would have.
Diane probably dissects more human hearts than most of us. Diane, how easy do you think it is to find the moderator band?
In the human, it's quite easy. I cut across it all the time. And some, just like we're all different listening to this webinar, so are our anatomic structures. So some people have a longer or thicker or shorter moderator band, just depending on their phenotypic presentation. So I see it all the time in humans.
I think some of the best I've seen are in hearts with hypoplastic left heart syndrome, because the right ventricle is so well developed.
And sometimes the trabeculations are much coarser, and sometimes you have a freestanding septomarginal trabeculation too. So I would agree with that.
I think that freestanding septomarginal trabeculation in right ventricular dilatation tells you something about the moderator band and the septomarginal trabeculation. Because when you've got chronic right ventricular enlargement, the moderator band and the septomarginal trabeculation are frequently lifted off the muscle. And so when you look at a specimen with this chronic RV dilatation, you can usually infer the dilatation from the fact that the septomarginal trabeculation and the moderator band are lifted off the surface of the right ventricle.
And this is no more than you would expect, because they are formed from the original trabeculations, and the trabeculations are a sponge-like mechanism within the cavity. They are discrete from the compact wall, and everything that you say is more and more evidence showing that the tension apparatus, the papillary muscles, the right ventricular trabeculations are all derived from the trabecular myocardium.
Yeah, and Bob, relative to the point you made about double-chambered right ventricle, I have seen hearts with a moderator band in the right place, but I've also seen hearts with another muscle bundle coming from
the septomarginal trabeculation more towards the base of the heart, towards the parietal wall. So you essentially have two, but one is much more towards the base than the apex.
Because we have a series of septoparietal trabeculations. The moderator band is just one of those series of septoparietal trabeculations.
Correct.
Okay, so that
Thank
is
you.
the end of our summer series. Hopefully for those of you who are still watching after the World Congress, come October, we'll look to set up a new series if that's what folks want. I'm sure Sasha and Grace will be discussing this. You guys will be seeing them in Washington. I will not be in Washington, but I wish you all the very best and have a great World Congress. As Adrian says, there's going to be many things to discuss. And thank you all for being with me. I think our summer series has been wonderful, largely due, as Adrian says, to the spectacular demonstrations made by Diane. And Norman, thanks for getting up so early in the morning so that you can join us.
My pleasure, Bob.
Okay, folks.
Thank you.
Enjoy the summer.
Thank you all.
Thank you very
Bye-bye.
much. Thank you. Bye-bye.